2 minutes for questions and discussion. Okay, and so we'll start the session. First one is Gladiss. The title is 2 in 1. You can start.
Good morning, everyone. I'll be presenting on behalf of Medicine 1, topic named 2 in 1. Coming to the case scenario of a 20-year-old boy, who's an engineering student from Dindigal. He presented with complaints of abdominal pain with loose stools 1 month back, fever since 1 month, and rash, generalized body rash since 1 month.
Male, is it?
He's a male.
Okay.
Yeah, his name is Mr. F.
Oh, is okay.
Coming to the history of presenting illness, he was apparently well until a month back when he developed diffuse abdominal pain, which was non-radiating, associated with loose stools, watery, small volume, non-bile stain, non-blood stain, and it settled with symptomatic management from a local hospital. 3 days later, he developed generalized pruritic skin lesions all over his upper limbs, chest, and back, associated with a low-grade fever without chills and rigors. With this complaint, he was admitted to a local hospital from 28th of September to 1st of October when he was treated with doxycycline, after which the skin lesions improved. During that admission on evaluation, he was noted to have low total counts in the range 1,700 to 2,000. Hemoglobin and platelet were normal. And since October 5th, he again had the recurrence of fever. This time it was high grade with chills and rigors. And there was worsening skin lesions involving the trunk and ear. Now the lesions became erythematous, maculopapular. However, there were no vesicles. He had no history of joint pain, no oral ulcers, photosensitivity, dry eyes or skin. There was no history of cough or dyspnea. There was no history of reduced urine output, hematuria or frothy urine. There was no history of loss of weight or loss of appetite. Past history-wise, in 2019, he was admitted in CMC Vellore with complaints of fever, generalized skin lesions, transaminase elevation on evaluation, eosinophilia was noted. He had generalized lymphadenopathy. Biopsy showed reactive changes. He also had splenomegaly on examination. He was diagnosed with Brest syndrome. He was treated with 1 mg per kg steroids, tapered and stopped, and was doing well thereafter. 2022, he again developed similar kind of a rash, but local hospital treatment he received was low-dose steroids, with which it settled. 6 months back, he had joint pain and swelling involving the right wrist, index, and middle finger, and it improved with symptomatic management. There's no significant personal history or family history. On examination, his pulse rate was 100 per minute regular. Blood pressure was 120 by 80 mmHg. Respiratory rate was 20 per minute. Saturation 99% in room air. He had a temperature of 102 Fahrenheit. On general examination, he had pallor. There was generalized lymphadenopathy in the submandibular region. There was one single 1 by 1 centimeter lymph node, the left axilla lymph node of 3 by 2 centimeters, the right axilla a single 2 by 2 centimeters lymph node, and multiple bilateral inguinal lymph nodes, largest being 1.5 by 1.5 centimeters. They were all firm and non-tender and non-matted. There was no icterus, cyanosis, clubbing, or edema. And he was noted to have erythematous papules in the bilateral axilla, abdomen, thighs, and they had a central crusting. Systemic examination wise, per abdomen, he had a palpable spleen around 4 to 5 centimeters below the left causal margin. So this is a syndrome of a 20-year-old boy with fever, skin rashes, pallor, generalized lymphadenopathy, and splenomegaly. Any thoughts on the differentials?
No differentials. Say something. 20-year-old fever, skin rash. Huh? Which one? Okay. So what about skin rash? Okay, fine. Only one differential. Okay, what were your
Differentials
thoughts?
we considered were lymphoproliferative disorders, leukemia, lymphoma, infection like tuberculosis, sarcoidosis, autoimmune diseases like SLE, a seropositive state. We also considered HLH and DRESS syndrome because of the past history of the same. On investigations,
Can you just go back? So can you just quickly tell what things were for and against each this differential? So first is okay, fine, all right.
lymphoma, he had a
Yeah, that's very obvious. Next.
tuberculosis again, 1 month history of fever, and
So
lymphadenopathy.
infiltrative disorders.
Yeah.
Okay, there's a differential. What is not fitting into that? In this syndrome, what cannot be explained? Quickly, one thing you can just say.
Not fitting. On examination, the lymph nodes were not matted in considering tuberculosis. There's no significant weight loss or appetite, to say more of seropositivity.
Yeah, keep on going, keep going.
On evaluation, his HP was 10.6 and the range was between 9.8 to 11 during his hospital course. Total counts were low, 1,200. And at the time of discharge, it was 4,000, but it was persistently low in the initial phase. Platelet counts were normal. Urea creat was normal. Urine routine, RBCs, microhematuria was present. Urine phase contrast microscopy showed isomorphic RBCs. Protein 2 plus was noted, so we quantified the 24-hour urine protein, which came up to be a nephrotic range proteinuria. And LFT showed a hypoalbuminemia with transaminase elevation, and an alpha elevation as well. His procal was 0.6, CRP was 16.3, coagulation parameters were normal. Tumor lysis syndrome workup was also normal. His retics were showed a hypoproliferative picture with an SOBSRP negative. High ferritin was noted. And bone marrow, we went ahead with bone marrow to look for any evidence of lymphoma, and that showed a trilineage hematopoiesis with non-specific reactive changes. Expert was also negative. BBVS was negative. ACE levels was 74. During the course of hospital stay, he also developed loose stools. So we evaluated for the same. Vital was negative. A malarial smear was negative. Echo V screen was normal, and the stool culture grew non-typhoidal salmonella. So we suspected a immunocompromised status in this patient, and we also considered autoimmune cause as our differential. So we went ahead with ANA, which showed a 2 plus speckle pattern. C3, C4 was low. Antiphospholipid syndrome workup showed a lupus anticoagulant mild positive. dsDNA was elevated. So he scored a 25 in the ACR Euler criteria and scored 3 in the clinical and immunological criteria, 3 each in the SLIC criteria as well. And we biopsied the lymph node, which showed a necrotizing lymphadenitis suggestive of SLE. Expert was negative. Ultrasound abdomen showed a splenomegaly and a mild right HUN. We went because it was a non-recurrent pattern of fever. When it was a recurring pattern of fever, we considered HLH also as one of our differentials, and we worked up for the same, which showed a high ferritin and high triglycerides with a normal fibrinogen. So based on the 2009 HLH criteria, which is the modified from the traditional HLH 2004 criteria, he satisfied the 2009 criteria. He had fever, splenomegaly, hepatitis, ferritin was there. That is one in the second set. And the third, he had a hypertriglyceridemia. So the diagnosis at the end of evaluation, we concluded was SLE involving the mucocutaneous system, renal because of microhematuria, subnephrotic proteinuria, hematological because of leukocytopenia, and SLE lymphadenitis with a secondary hemophagocytosis, lymphohistiocytosis due to macrophage activation syndrome. So I would like to discuss on HLH and MAS in this presentation. So HLH, hemophagocytosis, lymphohistiocytosis, is more commonly seen in infants less than 3 months. Though it is common in pediatric age group, it is seen in elderly as well. And in adults, there is a slight male predisposition. Macrophage activation system is nothing but HLH, a secondary HLH, secondary to rheumatological diseases. So considering secondary to secondary to SLE, and he did not and he satisfied the modified 2009 HLH criteria. We considered macrophage activation system syndrome, which is also called as reactive hemophagocytic syndrome. The pathogenesis is the normal NK cells and cytotoxic T lymphocytes, they eliminate the activated macrophages. But when there is a immune dysregulation, these macrophages are not cleared by the NK cells and CTLs, and the macrophages keep producing the cytokines, predominantly interferon gamma, and that creates a cytokine storm, and that is responsible for the multi-system involvement, extensive inflammation and tissue destruction, and that leads to a poor prognosis as well. So primary HLH and secondary HLH. Secondary HLH is what one classical example is macrophage activation syndrome, secondary to rheumatological illnesses. So the various triggers, a spectrum of various triggers, medications, malignancy, autoimmune diseases, infection. Infection is the most common trigger. Epstein-Barr virus is among the infection is the most common, almost 25%. And among the autoimmune disease, autoimmune Still's disease and systemic juvenile idiopathic arthritis are the more common causes of, are the more common triggers for causing macrophage activation syndrome. SLE causes 0.9 to 4.6% of the same. So this is a review of the literature which shows SLE with MAS had a mortality of 19% in one study as compared to 3%, and in the other studies by Huang and An as well, the mortality is high when SLE is associated with MAS when compared to without MAS. And these are the prognostic factors that they looked into: age over 50, presence of infection, leukopenia, thrombocytopenia, high CRP, high LFT, RFT, and presence of MAS on admission and throughout the hospital stay. These are the few mortality predictors in this study that they've noted. And in another study, by Sheth et al., autoimmune disease as a cause of hemophagocytic lymphohistiocytosis had a mortality of 11%, when compared to EBV is the highest, 44%, and autoimmune disease had 11%, caused 11% mortality. So coming to the treatment in short, this is the HLH 2004 protocol, wherein we start, it is an 8-week course, tapering course of dexamethasone, etoposide, and cyclosporin. And when the patient has a relapse, we go to the second week and again we restart the protocol. But here in MAS, which is secondary HLH, we don't follow the similar tapering course of 3 immunosuppressants. We start with a high dose of corticosteroids based on the study by Emeneghu et al. We initiate on high dose corticosteroids and we treat the underlying trigger. We take care of this. We control the infection, the underlying infection if it is present, and we start on supportive measures like PPIs, Shelcal, vitamin D, bacterial cover. All that is what we do in a secondary HLH, that is MAS. And once they are refractory, then we go to IVIG. And in case of malignancy or EBV being a trigger, we consider cyclosporin or etoposide. And if these patients continue to progress, if these patients continue to be refractory, then we go ahead with splenectomy or hematopoietic stem cell transplant. So in our patient, we did the same. He was having recurrent, he was having fever throughout the hospital stay, spiking 102, not less than 100. He was spiking a fever continuously. So we put him on injection hydrocort, suspecting a mass. And once his fever settled, we switched over to tablet prednisolone 60 mg OD, 1 mg per kg per day OD dose. We also added a second line immunosuppressant, mycophenolate mofetil, and bacterial cover. We added azithromycin. We didn't add Septran because he had cytopenias. Once the cytopenia is resolved, we plan to add Septran, and we added HCQ along with that, and supportive measures, as I mentioned earlier. We vaccinated him as well, and he had a mild HUN, which later during the hospital stay. So we could not go ahead with the renal biopsy. Nephrology wanted a clearance for the same. So he's planned to do a renal biopsy OPD basis. So learning point from this patient is pathogenesis of HLH and MAS, the treatment principles, and high mortality of SLE and MAS, which warrants early initiation of immunosuppression. Thank you.
You ruled out an infection as a cause for the fever for this patient before starting the immunosuppression.
Yes.
How did you do that? I mean, what all things you did?
First of all, the procal was low, CRP was low, blood culture serial 3 blood cultures showed negative growth, and we ruled out malaria and viral as well. BVVS was negative, so ruling out an underlying infection, and we started him on immunosuppressants.
Going back, anybody else has any question? Going back again, retrospectively, what do you think could have pointed in the history or evaluation investigations? What are the points which could have helped you, diagnosing the final diagnosis which you got earlier? Like, for example, what are the things which could have told you that, okay, this is more likely to be SLE with HLH rather than a lymphoma?
Initially, a thought process was TB lymphoma, but later on, the fever was spiking every day. It was a continuous fever, 102 Fahrenheit.
He had some past history of similar episodes, is it? Recurrent or no?
He had a recent history of high-grade fever that settled after 2 to 3 days with symptomatic treatment. But in the course of hospital stay, around a week, he was having everyday fever spiking 1 or 2, and with the HLH criteria being satisfied, we considered MAS.
How much anybody else wants to comment about that HLH criteria is being satisfied here? Something you want to say? Are you convinced the HLH?
So, did they do any molecular tests? Because now standard have changed to doing molecular tests to confirm HLH.
Yeah, molecular test, yes. We didn't do the molecular test because the patient was not affordable. But up to date, there is one reference which.
Second thing is the marrow is not shown any.
Yeah. But 50% of the case, apparently marrow does not show hemophagocytosis even if the patient has primary HLH. And serial bone marrow evaluation, when the patient is sick, we need not wait for bone marrow or the CD markers. We can initiate.
That's
there is
correct.
a high
What you're saying.
clinical suspicion.
My question is this: this is open to the house. Tell me, especially in patients with macrophage activation syndrome, which she said is a subset of HLH, which you describe it in patients with autoimmune causes. How do you differentiate somebody with low counts because of SLE and an HLH where the bone marrow is not showing hemophagocytosis? Somebody? Did you understand my question? Okay, so good thing is that they did not pulse with high dose. I mean, did you pulse with high dose steroids? No. So the reason was probably one is okay. So if the patient is very sick, then you don't have options. Okay, patient is having multi-system organ involvement with multi-organ failure, and there is no other differential in your only differential is microfracture. Maybe what she said, you don't always need all the criteria to treat. Yeah, okay, okay. Can go back and read about this. Next person.